Hey everyone, how's it going? Dr. Brandon Rosi here with Rosi Physiotherapy. I am a physical therapist. We have a private practice located down here in Palm Desert, California. So if you're ever looking to have some physical therapy needs, feel free to come check us out, give us a call. So anyway, we had a response to a post that I put online for October, which is a physical therapy month, asking any friends and family if they had any injuries. To give us a shout out and we'll see what we can do to help them along. And this post is specifically regards to Dr. Orly Leva, who is asking about bilateral ankle pain affecting him greater in the right than the left leg. He suspects Achilles tendonitis. So what he did was he sent us a message and said that he's got bilateral ankle pain. Right leg is affecting more than the left. He's an avid soccer player. He plays soccer recreationally about three to four times a week. He's been playing for the last 5 to 6 months or so, and he's been running in between for exercise. And this pain has no known trauma or known mechanism of injury, which means it's probably just a gradual onset. And so let's break it down. What I'm using over here on the screen that you'll be able to see is this program called Complete Anatomy. And what we'll do is we'll just talk grossly about the ankle injury, the ankle complex, and what is probably going on with his ankle. And then at the very end, we'll kind of discuss what he can do about it. So in order to kind of make this a little bit easier, I'm going to essentially get rid of the entire body except the leg. And then we're actually going to zoom in. Bear with me, it's a little bit harder to do this on a computer than it is an iPad. So essentially what we're looking at right here is just the bones of the right leg. You've got your tibia right here. We'll kind of lighten it up for you to see that. And then over here is your fibula. And now the tibia is this weight-bearing bone, the green one now. This is the weight-bearing bone of the leg. So actually if you do break the fibula, this guy over here, you can still walk on it. It would be very hard to play sports on it, but some do. But again, that most likely probably be in a boot. But essentially, so if we reference the tibia or the fibula, those are the ones we're talking about. With respect to the rest of this talk, we're going to turn the foot around to the side now, and this is the calcaneus, okay? And this is probably the heel of your foot, and this is what you'd most notably known as the heel of your foot, and also where the triceps surae, or otherwise the calcaneus, or the gastrocnemius, the gastrocs, and the soleus, the complex comes together, and they all attach to what is known as the Achilles tendon, or the Achilles heel, which is right around here. So what we're going to do is, before we actually add, let me get some of those words out of the way, before we add any muscles to the mix, I want to add a couple ligaments so we can talk about those. So all right, let's add a couple more. All right, there we go. So we're going to zoom in here a little bit. And so this is called the ATFL ligament. And this is the most commonly sprained ankle ligament, or in an ankle sprain, this is the most commonly torn ligament. And this is going to prevent an inversion, or in other ways, turning your foot inward, and so that you would actually rupture at this line right here between the anterior talofibular ligament. And here's the fibula, here's the talus, or the talus underneath, which the tibia is going to sit nice and comfortably on. And then over here, for the second most common, and I'd say at about 60-65% of ankle sprains is going to occur right here. And then, actually I don't think it's shown just yet. Alright, and right here is, here we go. And right here is the posterior calcaneal fibular ligament. Let's see, alright, so right here. And so this is probably the second most commonly ruptured ankle in an ankle sprain, whether completely ruptured or partially ruptured, depending on what grade tear it is. But again, these are, just to give you a rundown of what's going on in the ankle if you do have an inversion, or otherwise turning your foot inward so that the pinky toe is still on the floor and the big toe is kind of lifted up. And that would be an inversion sprain. And so what I want to do is just want to talk about those two and say, it could be an ankle sprain. Specifically for what we're talking about with Dr. Leva, that's not the case. But since we're already here, we thought, why not talk about it? So let's add some muscles in here so we can, break down what's going on. All right, and so back to what Orley was talking about is he referenced having some pain in his heel cords. He had some pain in his heel cords. So in the heel cords, it could be anything as long as the short peroneals, the brevis, this guy, which is known as the soleus, actually. And this is probably the strongest plantar flexor in the foot, along with the gastrocs, which is the most superficial muscle. Here's the plantaris, which has just got a really long tendinous attachment all the way going to the medial calcaneal, calcaneus, and then really, I'd say those are the big ones that we want to reference, mainly for what he reached out for. So we're going to get back to those, and let me back up just a little bit so you can see the addition of the soleus. There you go, and everyone probably is going to recognize that picture because that's most likely what you're going to see in like a physician's office or at any of your sports medicine clinic. That's what you'll see is kind of a picture of the gross anatomy in the leg. And so here again, this is the lateral head of the gastrocnemius, and here's the medial head. And both of these heads kind of essentially do the same thing. They come in here and they attach to the calcaneal tendon, which further comes along with the soleus, and they actually connect right about here, about I'd say three quarters of the way down, and they connect, and then the tendon actually becomes one and comes down here again. In this program, they call it the calcaneal tendon, most commonly referred to as the Achilles tendon, and that is where we would have the attachment, the distal attachment, meaning the further down attachment down the leg, to the calcaneus. So what I want to do is I want to kind of just give you a quick rundown of what is going on in those muscles and what these muscles are going to do. So what the gastroc and the soleus, or combined known as the triceps surae, what they do is they actually help plantar flex the foot, or essentially push the foot down as if you were going to push the gas pedal to go to speed in your car. And so I actually have it cut down already, a little section already taken away. So let's show you the motion of this exercise right here. So as you can see, it is going to help so that you can push the foot down. And this action is extremely important for propulsion or going forward. Anytime we walk, anytime we run, jump, skip, hop, this motion is extremely vital to allow us to go forward. And so when he says that he's having pain when he's playing soccer, and more importantly after playing soccer, that is a big deal because that lets us signify, is this related to an overuse injury, which it very well could be, but more on that to come. One thing I want to reference while we're here is I want to talk about this muscle up here, which is called the tibialis anterior. Okay, this muscle is essentially, think of it as your opposite muscle to the gastrocs. This one is actually going to allow you to dorsiflex the muscle, or dorsiflex the foot, in other words, lifting the toes up off of the ground while the heel stays there. And again, to give you a better representation of this, we'll show you with a quick video that is courtesy of the show, courtesy of the program, sorry. And so here, same thing, so it's going to allow you to do this. And the reason I wanted to show this is, specifically, is can I get you to understand that as this tibialis anterior muscle is turning on, or essentially activating or doing what its job is, that this posterior triceps surae complex, the soleus and the gastrocnemius, are actually going to turn off. In other words, they're going to allow them to lengthen as much as the muscle fibers allow them to. And in doing that is when you're going to get the maximum stretch in this gastroc soleus or even Achilles tendon repair, which is why after surgery they're commonly going to have you do, after a while, once you're released, you will do a long tendon stretch so that way you can get the muscle fibers and the muscles to stretch as long and elongate after surgery. So what I want to do again was show that. So, and again, it's this principal property called reciprocal inhibition that it says when one muscle is on, the muscle that does its opposite action has to turn off by default. So again, just wanted to give that as a reference point so we could kind of reference that more. So as you're running, think of the entire time when you're running, that leg is going to propel yourself forward, but likewise then that tibialis anterior has to suddenly turn on immediately. That way we don't drag our feet and trip over our own toes. and that way it can really pull our feet up high, our toes up and high, and so we run, we don't have to waste as much energy doing a much higher hip thrust on the legs, in the upper legs and the thigh, to allow us to advance forward and as quickly and swiftly as possible, which is what we want to do in sports. So as let's go back to the uncut section. As Orly was saying, is that he is having ankle pain actually on both sides, and most likely is common. In his case, it came from being inactive for a period of time before returning to activity. And as we age, a lot of times we like to, make up our mind one day and we decide that we want to just lose weight, we want to be active, and we want to return to a sport that we've once done before. Unfortunately, once you get over about the age of 16, 17, 18, you can't just jump back into it and expect there not to be any sort of a traumatic change, whether it results in a true injury or not. And so in his case, it probably just returned to a sport way too quickly and wanted to keep playing like he was a preteen. Small joke there, Orly. So right here, so what Orly was specifically saying is that he's having some heel pain. He didn't actually mention if it was more laterally or medially being, this is the big toe actually over here, medially being inside or towards the midline of the body, and laterally being more outside or away from the midline. And it actually does make a slight difference, or it does make a very valuable difference, is if his pain is, say, here on the lateral portion versus the medial portion, because if it is the medial portion, it actually could have some effect into what is known as the plantar fascia. And so what we're going to do is we're actually going to kind of show the bottom of the foot just a little bit. And so let's add the plantar fascia over here. Okay, so this really thick tendinous structure here would be what would be irritating the plantar fascia. Now, the reason I show this, and now you can't really see, is right after here, sometimes when you have a medial heel pain, it could be here and it could be here. The body's 2-point discrimination, or how much we can tell how much we hurt from here versus here, is not as sensitive or specific as we once thought. So it could be both, and that's why at this point I highly recommend, if you are having ankle pain or heel pain, to definitely get it checked out by your local physiotherapist, because they're going to be the best ones to tell you what's going on and why you're feeling it, and what exactly is best for you to do to treat that injury, or to treat that joint. But one more thing I wanted to talk about with him is actually because of the blood supply. Blood supply is how we heal. The best arterial blood flow is how we're actually going to heal. So let's just add some of the blood vessels in there. We're going to take off that last connective tissue layer, because that calcaneal bursa is getting in the way of my picture. And so over here you'll get the calcaneal branches off the posterior tibial artery, and then the calcaneal branches over here off the fibular artery. And so what they do is they come around, and so they're going to feed a little bit of that ankle and feed some of that ankle. And so the good thing is typically right here in this realm is we can actually keep a pretty good blood supply to the osteotendinous attachment, or where the bone meets the tendon. And so that way, the good thing is we don't have a rupture too often. When we do, it's normally a traumatic one, in that either a fall or a high velocity activity such as running, jumping, or kicking. And so most likely, if he is having pain, or Orly is having pain, is it's going to be up here a little bit into the tendinous attachment, and probably either roughly around here or around here. Now I would venture and say, if it is closer down right there onto the bone, then definitely want to have his entire foot checked out, just because it could be the leading cause of it. Now the one thing I wanted to mention, and the reason I showed the gastroc soleus complex, which allows you to plantar flex the foot, again, which allows us to press our foot down, or our toes go downward, versus the tibialis anterior, which allows us to lift our foot up, is because of how you are going to now treat this injury. So with a Achilles tendonitis, or a rupture, Achilles tendonitis versus a tendinosis versus a rupture would be a major change in how to treat it. To save myself from giving any sort of recommendation, I am not diagnosing you, and if you at all want to take my advice, please don't, unless you come see us as a therapist and I can tell you one-on-one after an examination what is truly going on. Aside from that, that's my disclaimers, is definitely go get treated by either a doctor of physical therapy, a sports med physician, or someone else that is qualified to do so. And as an added statement, and just, do your due diligence first. So again, so if you have an Achilles injury in the tendon that is much higher up here, then most likely you are you're much more safe to prevent adverse reaction to do an exaggerated or an eccentric heel stretch. So it would be that going back to, let's see over here, and it would be that um, this guy, so that we can actually dorsiflex the foot, but we're doing that to actually stretch. So what I would do is I'd get that foot right about there, and most of the time you can do that by putting the forefoot of your foot on a step and then actually allowing the back of your foot to drop down below parallel, which allows you to stretch those fibers out. And that again is if the ankle pain is a little bit higher up and around that region, whereas if it is closer in essence to, let's get back to this picture, if it is closer to the heel cord, or the heel cord, the calcaneus itself, then I actually would recommend you do not stretch it beyond this level, in which case, for Orly's case, the best thing that he could do for it in a short term is to get himself either an athletic trainer or, again, a physiotherapist that is going to tape his ankle to essentially try to stabilize the ankle as much as possible to prevent any dorsiflexion as possible. It will also limit his plantar flexion, and I do not recommend this as a long-term solution, but in the short term, it would be a good option. Him specifically also said that he was taking some ibuprofens, and as far as the NSAID use, I would not recommend it for long-term use. And again, more importantly, NSAIDs are one thing, but when you talk about a corticosteroid injection, which I believe now is probably the most important time to talk about steroid injections, are that I would highly, highly, highly recommend an alternative to a corticosteroid injection, especially for any form of heel pain, because the Achilles tendon is known to rupture, have an incidence of rupture rate more than 6 times as prevalent as in those who had not had a corticosteroid injection. And that's because the corticosteroid actually thins out the tendon itself, and the last thing we want is to thin or attenuate the ligament that is already compromised. And so really, I would recommend, conservative management that does not involve, pharmacological management. But again, I'm not a physician, so as far as talking, drugs, I'd say go to an MD or, even a PharmD, for that discussion, or a DO. So with him specifically, I wanted to add one more thing, because he did say that his pain is actually occurring or most bothersome actually at the very end of soccer. And so one thing that a lot of people kind of forego or miss is this guy right here, which is called the calcaneal bursa. Bursa is essentially our little fat pad, if you will, or our pillow between the muscles and the tendons and the bones between the subcutaneous tissue, and that's this guy right here. And it's essentially, just think of it again as like that little pillow pad that prevents that traumatic bruising or bumping, as those heel cords are going to keep rubbing and flossing across that guy. And since he says that there is an inflammatory component, it actually very well could be a bursitis, which would also be why NSAIDs or ibuprofen would be making him feel a little more comfortable, especially in the short term. But as far as long term, again, it will help in the immediate now. Same thing, actually, a corticosteroid injection will help in the immediate now, but long term it'll actually be worse than better. One thing I would truthfully recommend for Dr. Leva is to give his foot a break. Essentially, I'd say taking about 2 to 3 days off straight with avoiding running would do a whole lot of good for that injury, as far as letting these blood vessels supply to the heel cord, allowing it to give that bursitis a chance to calm down and get better. One thing that he can do right now is for that heel cord, especially if it is that bursa that is the bother, is so right here is about actually where I would say the back lip of your shoe is. And so every time we walk, our foot, believe it or not, actually scoots up and down in and out of that shoe hundreds and thousands of times a day. And that's just every time we take a step, our foot lifts and it lowers and it lifts and it lowers. And essentially what you're doing is you're going to keep rubbing this area right here a lot. And so one thing you want to make sure you're doing is, one, you want to make sure you're wearing socks. And two, you actually want to make sure, I know it's very fashionable to wear a sock that is actually covers up your heel, in which case leaves the skin more exposed. But what we want to do more importantly is actually make sure that you're wearing a sock that's high enough to go above the shoe itself. That way, if it is rubbing, there is some form of, protective barrier, cotton barrier. And in his case, if he's wearing an athletic sock or a soccer sock, it is actually probably much better. As far as that, in addition to that, there is the whole ice debate. Since he is having active inflammation, I would definitely recommend ice in the short term. But me personally, and the benefits I get as a clinician, I recommend heat, because in the event that it is at all an insult or an injury to the Achilles tendon itself, you don't want to actually freeze or cool down that tendon, because it's going to make those fibers shorter and more taut, in which case it's actually going to aggravate it more in the long term. So without anything else, again, if you have any questions, I highly recommend that you go see a physical therapist or a doctor of physical therapy in your area. And if you want to find one or you don't know how to find a good one, the easiest and quickest way to start is go by Facebook and online social media. Ask your friends, ask your family, who they've gone to, and they'll give you a recommendation. If not, you're always welcome to go to APTA.org, which is the American Physical Therapy Association.org. You click on the little tab in the far right corner called Find a PT. Type in your zip code, and it'll give you a list of all the physical therapists in the area with their credentials, and then you can start your search from there. So thank you all for watching again. I hope this gave you some help. If you are in the area and you want to discuss your ankle injury more, feel free to give us a call. I will leave the details in the description, and thank you so much for watching.